Morning, everybody. My name is Dr. Vidya Prakash. I am a professor and infectious diseases faculty at Southern Illinois University School of Medicine. And I also have the honor and privilege of serving as president of Health for the World's SIU School of Medicine Infectious Diseases chapter. Welcome to Health for the World Grand Rounds. I am delighted and honored to introduce our speaker today. She is my friend and my colleague and esteemed faculty, Dr. Marcela Rodriguez. Dr. Rodriguez is an associate professor and pediatric infectious diseases faculty at SIU School of Medicine, where she also serves as clinical director of the Pediatric Infectious Diseases Clinic. Dr. Rodriguez, we are so thrilled to hear from you and to learn more about histoplasmosis in children. Thank you so much.
Good morning, everybody. Thank you, Dr. Prakash, for this kind introduction. It is a pleasure for me to be here. Thank you for the invitation. And I will be talking about histoplasmosis in pediatrics. I'm going to start with two cases, actually two patients that we took care of here in our division. And then I will go through the actual topic. So case number one, this is a 4-month-old twin baby boy with prolonged fever, anemia, and direct hyperbilirubinemia. So the fever started over 2 weeks prior to admission. While vacationing in Florida, he presented to the ED with a fever of 102. He was diagnosed with an ear infection and he was added on amoxicillin. 4 days into amoxicillin, the fever continued and he was seen again in the ER with a fever of 103. At that point, the antibiotic was discontinued and managed as a viral infection with supportive care. On the day of admission, he had a 4-month well child check, and he was noted to still have a fever of 101, and this was his 16th day of fever, so over 2 weeks. He had associated symptoms, which included a frequency of foul-smelling stools, decrease in oral intake, mild abdominal distension, and 3 to 4 episodes of emesis for 2 to 3 days prior to admission. The mom denied any cough, rhinorrhea. Twin brother was healthy, and there were no known sick contacts. As far as his past medical history, so he was born to a 27-year-old mom, G2P2 at 36 weeks of gestation. His birth weight was 6 pounds 7 ounces. He was a product of a twin pregnancy, vacuum-assisted vaginal delivery. Prenatal serologies and GBS status was negative. He had an uncomplicated postnatal course, no history of previous hospitalizations or surgeries. Immunizations were up to date at 2 months of age. He was developmentally appropriate and he didn't have any drug allergies. Family history was unremarkable. Social history, so he lives with his parents, his twin brother, and a 6-year-old sister in Taylorville, Illinois, the Midwest of the United States. They live in the country, no history of mosquitoes or ticks. He has a pet dog, no other animals, no daycare exposure. There was some recent cleaning and renovation of the garage in their house, and a recent trip to Florida before his illness. So on examination, the infant was febrile with a temperature of 38.8. He was tachycardic, and his exam was remarkable for hepatosplenomegaly. So this was his initial workup that showed anemia of 7.4. He had thrombocytopenia. He had increase of AST and slightly increase of ALT, and he also had an increase of T and INR. So he was added on empiric antibiotic with ceftriaxone and vancomycin. Infectious diseases and hem-onc were consulted to rule out hemophagocytic lymphohistiocytosis. He had ferritin, LDH, and triglycerides, which were only slightly elevated. And he ended up having a bone aspiration since he had a fever of unknown origin. And initial workup was basically negative. So this is the ID workup. So he had multiple tests that revealed blood culture negative, urine culture negative. He had CSF panel completely negative, including bacterial, viral, fungal cultures. He had a DFA for respiratory virus that came back negative. We did serologies for EBV, CMV, hepatitis, HIV, Bartonella, all of which that came back negative. He had a CMV blood PCR negative, CSF enterovirus PCR negative. We did blood PCR for other illnesses, including dengue, Ehrlichia, rickettsia, chikungunya, all of which that came back negative. He had arbovirus serum and CSF serologies negative. PPD was negative. CD4 count was a slightly decreased, but not seriously decreased. So he ended up having imaging, which showed significant hepatosplenomegaly without evidence of pathologically enlarged lymph nodes in chest, abdomen, or pelvis. This is his scan that I just want to highlight. Huge liver and very big spleen that were very, very evident on physical examination. So he underwent a bone marrow aspiration in view of the persistent fevers, and it showed granulomas with rare fungal yeast forms. The blood fungal culture and bone marrow culture were positive for Histoplasma capsulatum. Then we proceeded more workup for histo, and histo urine antigen was significantly increased at 16.29 nanogram per milliliters. Equally, his histoplasma serum antigen was positive at 6.98. He had a histoplasma CSF antigen that came back negative, and histoplasma serologies were significantly positive with a complement fixation yeast phase of 1 in 128, mycelial phase 1 in 16, and immunodiffusion test positive for both M and H bands. So this is a picture of his bone marrow H&E, and you can appreciate the granuloma. Clearly, we can see that here. And that this is the bone marrow GMS stain that showed the yeast forms. So these are pictures of his blood culture that were positive for histoplasma. So after we got these results, antibiotics were stopped and liposomal amphotericin B was started. And you can clearly see that his temperature curve, improved drastically. Fever went away. Because of anemia and thrombocytopenia, he required platelet and blood transfusions and a couple of doses of GCSF. Then he had a brain MRI. We were looking at disseminated disease. This came back negative. Broviac was inserted and he went home on IV amphotericin, which follow up in ID clinic. He received 4 weeks of IV amphotericin and we followed him with 12 weeks of oral itraconazole. He tolerated treatment very well. Histourine antigen was followed and it decreased from 5.28 at 3 weeks of therapy, and it was negative at the end of therapy. White blood cell count, hemoglobin, and platelet count normalized, and his hepatosplenomegaly resolved. So we had a very good outcome in this infant that had disseminated histoplasmosis. So this is my second case. This was actually my patient. I remember him very well shortly after I came from fellowship some years ago. So this is a very different patient, 7-year-old male with past medical history of ALL on consolidation chemotherapy with persistent fever and elevated liver enzymes. So 8 days prior to admission, he started having fevers with a Tmax of 101.8, chills and emesis. He was admitted for dehydration and a head CT showed pansinusitis and he was started on Augmentin. Despite Augmentin, he had persistent fevers. He required to be readmitted. He was having some non-bloody diarrhea and vomiting. He had some ongoing cough, congestion, and runny nose for more than 10 days. His past medical history, so he was diagnosed with ALL 40 years prior to this presentation. He had a poor placement for his chemotherapy. He was on prophylactic Bactrim, and he was also currently on 6-MP and methotrexate at the time of the diagnosis of this illness. He didn't have any drug allergies. Family history was negative. He had a cat, probably scratched him about 1 to 2 weeks prior to this presentation. As far as review system, he had the fever, as I mentioned before, headache, nausea, vomiting, myalgia, abdominal pain, back pain, rash, and cough. So on examination, he looked tired, fussy, very uncomfortable. He had significant hepatosplenomegaly, and he had a blanching erythematous rash in his upper back. So these were his labs, significantly abnormal. He had leukopenia, anemia, lymphopenia, and he had, again, increased AST and ALT, so transaminases. So infectious disease workup was performed, and it was unrevealing at that point. We had CMV, EBV, parvovirus serologies, all of which that came back negative. We did a multiplex PCR panel that came back positive for rhinoenterovirus that wouldn't explain all his symptomatology. We did blood, urine cultures that were negative. We did Bartonella serologies that came back negative. Hepatitis panel came back negative. We did a TB quantiferon gold that came back negative. Then we proceeded with some imaging. He had abdominal ultrasound that showed hepatosplenomegaly, no biliary dilatation. He had a chest X-ray that showed a right lower lobe infiltrate, and echocardiogram, which was normal. So he was started on ceftriaxone and azithromycin empirically for possible pneumonia in view of the findings on chest X-ray. Despite antibiotic treatment, he continued to be febrile with a temperature of 40 degrees. He ended up having a bone marrow aspiration and a lumbar puncture on day 5 of hospital stay. CSF were unremarkable, but his bone marrow pathology revealed the diagnosis. He had scattered non-necrotizing granulomas. His GMS stain showed rare yeast, no evidence of recurrence of ALL. So then we ordered fungal studies, and we started him on empiric IV liposomal amphotericin B. His histo studies came back with immunodiffusion positive M and H bands. His complement fixation was low, 1 in 8, and he actually had urine antigen 1.84 and blood antigen positive 1.77. So these are his actual pictures, the H&E stain and the GMS stain showing granulomas and yeast forms respectively. So we did proceed with imaging and some more workup. He had a brain MRI that came back negative. We stopped IV antibiotics and continued the IV amphotericin B. The fever results after 2 doses of IV amphotericin, which is impressive. Liver enzymes improved. He went home on IV amphotericin with close follow-up of CBCs and electrolytes. So this is his temperature curve. This is when we started amphotericin B, and then, very prompt response to the treatment. He tolerated this very well, but as a complication from treatment, he developed some hypokalemia, and we need to give him some oral potassium. After 21 days of IV amphotericin, we switched him to oral itraconazole. And then he finished 12 months, a full year of systemic antifungal treatment. We did monthly urine histoplasma antigen levels that turned negative towards the end of treatment. He recovered, and he's doing very well. So now I'll talk about histoplasmosis. This is the most common pulmonary and systemic mycosis. There is worldwide distribution. In the US, there is about 500,000 cases per year. In the Midwest, the incidence is pretty high. It's about 6 cases per 100,000 population compared to 3.4 cases per 100,000 population in other regions. This is an opportunistic infection in immunosuppressed patients. Histoplasmosis is a dimorphic fungus, which refers to a fungus that assumes one of 2 different physical forms as directed by environmental influence, such as temperature or humidity. So one of the forms is called environmental form, that is a mycelia and saprophytic form. This has microscopic elements that are called microconidia that aerosolize and lead to wide environmental distribution and are infectious or on inhalation. The spores are at about 2 to 5 micrometers in diameter, and they grow at 25 degrees Celsius. The human form is the yeast form, and usually higher temperature, as it is in the body, at 37 degrees Celsius. So this picture just shows the saprophytic forms with the microconidia on the left, and the top and the middle picture, and then there is also the yeast forms that are in the top right and the bottom picture. So this fungus was first described in Panama in 1905. Histoplasma capsulatum, var capsulatum, is the most common cause of endemic mycosis in the US and throughout the world. It grows well in warm, moist environments. There are some certain soil compositions, including high nitrogen content, high carbon content, and lower pH that enhance the growth of the organism. So these fungus is encountered in most parts of the world, not only the US, but in Africa, Asia, Europe, South America, and of course, North America. The transmission is almost exclusively by aerosolized and subsequent inhalation of spores. Human transmission is extremely rare, and prior infection confers partial immunity. Reinfection can occur, but requires a larger inoculum. So as everything in infectious diseases, history is very, very important. So exposure history, we have to dig a lot and try to look for potential sources of infection. So history of caving, landscaping, work with soil, exposure to construction, exposure to bird droppings, playing in hollow trees, playing in a barn, all those are risk factors to acquire histoplasmosis. But actually just living in the Midwest, just living here will put you at higher risk because we're a highly endemic area. As you remember in our patients, the infant, they did recent cleaning and renovation of the garage. So I think that, was one of the risk factors for that baby. So this is a map that is showing basically the areas that are endemic for histoplasmosis in the United States, including the central and eastern United States and the Midwest, which includes the Ohio, Mississippi, and Missouri River valleys. And the other map on the right-hand side just shows the different endemic mycoses, and you can see histo and blasto in the Midwest. So we see a little bit of blasto here too. But as an example, coccidiomycosis is more in the West in states like Arizona and California. So very important to know your travel history or where you live to think about the endemic mycosis. About pathophysiology, so this organism has unique biologic capabilities, has the ability to infect and gain access to macrophages. It survives and replicates in macrophages and disseminates, and then it becomes reactivated when the host immunity is down. The successful clearance of infection depends on integrity of cellular immunity, and symptoms happen in fewer than 5% of infected people. So most of the people are asymptomatic. Incubation period is about 1 to 3 weeks in non-immune hosts and 4 to 7 days in re-exposure. So this picture just shows the pathophysiology. I'm gonna go through that. I really like pictures, kind of like to learn a little bit easier. So everything starts with inhalation of microconidia that has the spores. Then the conidia germinates in the alveoli and proliferates as yeast because the temperature changes. There is subsequent granuloma formation with central necrosis. Yeast cells access the reticuloendothelial system via pulmonary lymphatic system and hilar lymph nodes. Then there is dissemination with splenic involvement. And then in about 2 to 4 months, then there is a pulmonary lesion that resolves in 2 to 4 months. And what we can see in patients that actually, control the infection, we see calcification like gone complex that we see in TB. So again, clinical manifestations, so 95% of infected individuals are asymptomatic. So we don't even know they had histoplasmosis. Sometimes we just find later on in a chest X-ray an incidental finding of a calcification. So we assume the patient had histo and resolved infection on his own. 60 to 90% of the symptomatic patients manifest acute pulmonary symptoms. It is sometimes difficult to distinguish between bacterial and viral lower respiratory tract infections compared to histoplasmosis. There is greatest severity of fever, malaise, and fatigue, which may lead to the suspicion of histoplasmosis. So these just shows the common causes of pediatric fever of unknown origin, and you can tell that histoplasmosis is listed there. So every time you have a child that has a prolonged fever, you have to think about histoplasmosis if you're in an area that is endemic for that. So there are several syndromes of histoplasmosis. I'm gonna go through them, but acute pulmonary histoplasmosis is the one that we see mostly clinically. Chronic cavitary pulmonary histoplasmosis, we don't see this as commonly in pediatrics. Mediastinal lymphadenitis, mediastinal granuloma, fibrosing mediastinitis, luckily we don't see these as frequent. Pulmonary nodules, progressive disseminated plus minus meningitis, and ocular histoplasmosis syndrome, that is chronic chororetinitis. So let's start with acute pulmonary histoplasmosis. So most of the time, this is a self-limited illness with fever, chills, cough, and malaise. Most patients recover 2 to 3 weeks after the onset of symptoms without any treatment. They may present with prolonged illness, weight loss, high fever, dyspnea, fatigue. Pleural effusion is very, very rare in acute pulmonary histoplasmosis. So this is just a CT scan that shows classic snowstorm appearance of acute pulmonary histoplasmosis. So chronic cavitary histoplasmosis, this is very, very rare in children. Older adults with COPD can have these, and it can mimic pulmonary TB. It also happens as an opportunistic infection in adults with emphysema. Patients would present with fever, productive cough, weight loss, fatigue, and can be fatal if it's not treated. Mediastinal lymphadenitis is also called granulomatous lymphadenitis. So there is an acute primary infection with fever, weight loss, mediastinal mass visible on chest X-ray. There is inflammation and compression or obstruction of contiguous structures within the thorax. Symptoms can be chest pain, cough, and/or atelectasis due to bronchial compression. And children are more likely than adults to present with airway obstruction in view of the sizes of their airway. So this is a CT that shows metacellular lymphadenitis. So mediastinal granuloma, it's a large, mostly caseous mass of mediastinal lymph nodes that coalesce into a single encapsulated lesion, which is usually located on the right paratracheal region or the subcarinal area. The caseous center can spontaneously drain via fistula or sinus tract to the bronchus, the skin, or the esophagus. So fibrosing mediastinitis, this is an uncommon sequela of metacellular lymphadenitis. It usually has subacute or chronic manifestations. It doesn't present acutely. It happens mainly in adolescents. So what happens, there is a granulomatous inflammation, which may progress to dense fibrosis and may cause stenosis, obstruction and malfunction of contiguous critical mediastinal structures like central vessels and airways. This is progressive and unfortunately is irreversible. It does not respond to antifungals nor anti-inflammatory agents such as steroids. And patients would have a lot of complications from these, including superior vena cava syndrome, obstruction of the trachea, and the bronchi. So these are some pictures showing fibrosing mediastinitis. And you can see, patient would have obstructions of airway, obstructions of great vessels, and they can be severely symptomatic. And this is very difficult to treat. So pulmonary nodules is actually that we see often. So long parenchymal sites of infection may contract and then persist indefinitely as long nodules or histoplasmomas. Calcification is usually found in the center or in concentric ring. And usually these are just findings that are incidental on chest X-ray or CT. So this is a chest X-ray and a CT that shows pulmonary nodules. On the left, there is a 10-year-old male with calcified left hilar lymph node secondary to histoplasmosis. And on the right, there is the CT that shows the single pulmonary nodule. So there is also progressive disseminated histoplasmosis, which is what our patients have, caused by immunodysfunction, causing an inability to control the organisms during dissemination. So this excludes the transient fungal dissemination, that uniformly occurs in early primary infection and is halted by acquired cellular immune response. The clinical illness does not improve after at least 3 weeks of observation, and that is associated with physical or radiographic findings and or evidence of involvement of extrapulmonary tissues. So the patients who have progressive disseminated histoplasmosis will present as fever, weight loss, organomegaly, progressive elevation of hepatic liver enzymes and hematologic abnormalities. Basically, what our patients had is well described in infants and immunosuppressed children. And dissemination can lead to infection of virtually any organ. So you can have compromise of the skin, osteoarticular lesions, endocarditis. You can have interstitial nephritis, parotitis, meningitis or cerebritis, and GI involvement. So there is this particular form that is called disseminated histoplasmosis of infancy, which is what our first patient had. So presumably secondary to relatively immature cellular immunity. Most are found to be immunologically healthy. A patient would present with a persistent unexplained fever, weight loss, or failure to thrive. They would have almost universally hepatosplenomegaly. They would have hematologic abnormalities and coagulopathy. And one thing is that pulmonary symptoms are less common than in older children, in this case with disseminated histoplasmosis of infancy. So in this patient, the chest X-ray can be normal or show just focal or diffuse infiltrates. Meningitis can happen, is common in up to 60% of cases. These can be fatal without treatment. However, if we treat them, the prognosis is very good. And if untreated, they develop malnutrition, diffuse adenopathy, pneumonia, DIC, pancytopenia. So this is a study that looked at infants with disseminated histoplasmosis, and I just want to highlight that all of them had fever, failure to thrive, and splenomegaly. Some of them had cough and respiratory distress. Some of them had generalized lymphadenopathy, but I just want to highlight that all of the kids had fever and splenomegaly. So see, these are the abnormalities. All of them had anemia. 80% or so had thrombocytopenia, an increase in PT and PTT, and about 3/4 of patients had leukopenia and neutropenia. So this is a chest radiograph of a severely 4-year-old child exposed to a large inoculum of histoplasma when his parents were cleaning the fireplace of an abandoned house. So histoplasmosis in the immunosuppressed child, like our second patient, so they would present with prolonged fever, weight loss, they can have interstitial lung disease, hypoxia. Once the fungus disseminates, extrapulmonary manifestations would include oral ulcers, destructive bone changes, endocarditis, rarely meningitis. In patients with HIV, most of the patients would have pulmonary involvement, hepatosplenomegaly, lymphadenopathy. They have sepsis-like syndrome with multi-organ failure and DIC. And disseminated histoplasmosis is an AIDS-defining illness. Okay, so how we diagnose histoplasmosis? So first of all, we have to have high index of suspicion based on the presentation and the epidemiology risk factors of the patient. But when you think about it, then what we start with usually are serologies. So these are mostly useful in subacute or chronic pulmonary disease. There are 2 types of serology testing, one called immunodiffusion and the other one complement fixation. They can take up to 4 to 8 weeks to be positive, and they're about positive in 90% of immunocompetent patients. But only half of immunosuppressed children and adults with disseminated histoplasmosis are seropositive. So complement fixation antibody assay is a quantitative test. These will detect mycelial phase and yeast phase and a 4-fold increase in mycelial phase or a single titer of more than 1 in 32 in either test will be diagnostic. On the other hand, immunodiffusion antibody assay is a qualitative test. It doesn't give us a number, it just says positive or negative. This is slightly more specific. These measures the M and H bands. So the M band is more common and can be detected in early infection and last a long time, more than 6 months. The H band presenting disseminated disease and highly suggestive of active infection. So there is this other radioimmune assay for histoplasma antigen in urine. This is a rapid and semi-quantitative test with high sensitivity. It's usually useful to monitor patients with disseminated disease, mainly immunocompromised patients. The urine histoplasma antigen has a sensitivity of 95% in disseminated disease and only positive 10 to 40% in patients with acute pulmonary disease. A negative test does not exclude infection. And usually when they're positive at baseline, then we repeat it at 2 weeks, 1 month, every 3 months during the therapy, and 6 to 12 months after treatment is stopped. This is a very good marker to follow when you have an initial positive test. And for example, in our hemo kid with leukemia, we follow that towards the end until he basically cleared his urine antigen. So as in most infectious diseases, the culture is the definite method of diagnosis. The organism may take up to 6 weeks to be identified. Sensitivity of culture varies based on the site of infection and host risk factors. Sputum culture may be positive only in 10% of cases of acute pulmonary histoplasmosis. So sensitivity rises to 60% in cavitary disease and to 90% in VL from AIDS patients. But sputum culture on its own is not going to be positive in a lot of times. Histoplasma grows in blood, bone marrow, and tissue specimens. And as you can remember, in our 2 patients, we diagnosed them with bone marrow aspirate. Histopathology will reveal non-caseating granulomas. So I'm going to go over the treatment of histoplasmosis. So right now, unfortunately, fortunately, we have the clinical practice guidelines from the Infectious Disease Society of America. They were done in 2007, so there we need an update on these, but this is what we still follow. And first of all, I want to highlight that not everybody needs treatment. So as you recall, most of the patients, 95% of them are asymptomatic. They don't need treatment. And of the 5%, actually, a lot of them still don't need treatment. So I just want to say the indication for antifungal therapy. So definite indication, proven or probable efficacy are basically acute diffuse pulmonary infection in the patients that are moderately to severely symptomatic. Chronic cavitary pulmonary infection definitely requires treatment. Progressive disseminated infection requires treatment, and CNS infection. So these 4 entities for sure we need to treat. The ones that are uncertain indication, unknown efficacy are acute focal pulmonary infection in an asymptomatic case or mild symptoms that persist for 1 month. You might need treatment, you might not need treatment. Mediastinal lymphadenitis, mediastinal granuloma, and inflammation syndromes treated with corticosteroids. And there is definitely not recommended treatment for patients with mediastinal fibrosis. As far as antifungal treatment, pulmonary nodules, bronchiolithiasis, and pressure ocular histoplasmosis syndrome. So a couple of things. Again, the majority of patients with histoplasmosis are not treated, and most of them actually don't even get diagnosed. And then another key point that I want to highlight, all immunocompromised patients should be treated. So just to go over a summary of the guidelines. So if patients are asymptomatic, no treatment is needed. If you have mild to moderate acute pulmonary infection, most of the time treatment is unnecessary unless you have failure to improve within 4 weeks. So you have a patient that has persistent symptoms over a month, then you have to start considering giving them antifungal treatment, and the drug of choice would be itraconazole, and we give between 6 to 12 weeks. If you have a moderately to severe acute pulmonary infection, then you would start with amphotericin B for 1 to 2 weeks, followed by itraconazole for 12 weeks. These patients with moderate to severe acute pulmonary infection, we also give them systemic corticosteroids for 1 to 2 weeks. Chronic cavitary pulmonary histoplasmosis, we don't see very frequently in children, but usually it is recommended to give patients itraconazole for at least 1 year. Mediastinal lymphadenitis, if symptomatic for more than 1 month, itraconazole is recommended for 6 to 12 weeks. Steroids should be given if there is obstruction or compression of contiguous structures. If there is mediastinal granuloma, usually treatment is not recommended. And pulmonary nodules, no treatment is necessary. So how do we treat progressive disseminated histoplasmosis, as our children had? So we give them amphotericin B at the beginning for 1 to 2 weeks, followed by itraconazole for 6 months. The use of itraconazole as a sole is not recommended. We have to start this patient in amphotericin B. Longer therapy may be needed for patients with severe disease or if they're immunosuppressed. And some patients that are going to have ongoing immunosuppression, sometimes they will need lifelong suppressive therapy with itraconazole, so they don't have reactivation of this infection. So antigen levels should be measured during therapy and for 6 to 12 months after therapy is ended to monitor for relapse. In children that will start new immunosuppressive therapy and already finished histoplasmosis treatment, urine antigen should be obtained before therapy and every 2 to 3 months afterwards. Relapse rates at 10 to 15%. So we have to keep that in mind after we finish treatment. And persistent low-level antigenuria may not be a reason to prolong therapy. So as far as antifungal agents, I'll start with amphotericin B. There are several kinds of amphotericin B. What we use right now is the liposomal version of these because of less side effects. This is a fungicidal drug. It's not absorbed orally or intramuscularly. It has to be given IV. It has adverse reactions. So infusion-related reactions could be fevers, rigors, chills, myalgia, nausea, vomiting, headache. As far as nephrotoxicity, it can cause elevated BUN and creatinine, hypokalemia, and low magnesium and tubular acidosis. You can have also bone marrow suppression with this medication, including anemia, leukopenia, thrombocytopenia, and it can also cause cardiac arrhythmia. So we have to give this medication with a lot of caution. The amphotericin B lipid formulations, they're less nephrotoxic. Infusion-related reactions are less frequently. An infusion over 2 hours is what we use for these lipid formulation versus 6 hours of conventional amphotericin B, which is a big difference. Okay, so just to summarize, take-home points, histoplasmosis is endemic in the Midwest. Disseminated histoplasmosis should be in the differential diagnosis in children with fever of unknown origin, especially in infants and immunocompromised hosts. Isolated pulmonary nodules with central calcifications are frequently found as an incidental finding on chest X-ray, and no treatment is necessary in these cases. And with this, I would like to finish my presentation. Thank you so much for having me today, and I will be happy to take any questions.
Dr. Rodriguez, thank you so much for an exceptional presentation. I always learn from you, and this is no exception. I continue to learn from you. One question that I have is, do you see CNS manifestations of histoplasmosis in pediatrics? Have you seen any CNS manifestations like meningitis or solitary lesions?
That's a good question. Luckily, I have not seen any cases of CNS presentations, but we have to look for that. And that's why we, when we find disseminated histoplasmosis, we have to do a lumbar puncture and brain imaging to look for those. So far, I haven't seen, but we haven't seen a lot of disseminated cases, maybe less than a handful, but it is well described in the literature and we have to look for that.
Yeah, absolutely. We have seen case series of CNS manifestations of histoplasmosis in adult patients, and commonly they present with a chronic meningitis picture that nobody can really understand what the etiology is, or sometimes even solitary brain lesions to even hydrocephalus. So as you said, I'd like to highlight, it's important to look for it, to have it on your radar in endemic regions. And I just wanted to share an anecdote of mine to your point about, being immunocompromised as being a big risk factor for progressive disseminated histoplasmosis. I had an adult patient with rheumatoid arthritis who was started on a TNF, tumor necrosis factor alpha inhibitor. And within several months of being on that immunosuppressive therapy, she started having large ulcerative gum lesions and were biopsied and consistent with histoplasmosis.
Wow.
Yeah, and as you said, by definition, even though she wasn't acutely ill, if you look at the pathophysiology of it, that was definitely a disseminated infection. And so she was treated with a little over 12 months of antifungal therapy, and the lesion completely resolved and she did well, and obviously was taken off of immunosuppressive therapy. But just another highlight of, the immunosuppressed status being a big risk factor. So I wanted to put it out to the audience to see if there are any questions for Dr. Rodriguez. Somebody wrote, great presentation.
Thank you.
Any other questions? Okay, well, Health for the World team, again, many, many thanks. And Dr. Rodriguez, special thanks to you.
Thank you for having me today. You guys have a good day.
You too. Bye-bye.
Bye-bye.